Uh, am I audible, Vaishnav? Am I audible to everyone?
Yes, sir, you are.
Okay, thank you. Okay, we'll start. Good afternoon, one and all. Myself, I'm James Das. I'm working in Parliamentary physiotherapist from last 1.5 years. I'm currently I'm heading the department. It was a nice, good opportunity to see you all and discuss a case with you, discuss a session with you, and I welcome you all for this session. I think this is our 11th session. We have been studying and learning palliative care since from the first session itself. And today we'll be discussing on care of bedbound. Yes. So before we start the session, one second, Vaishnav, can you go back to the first slide? Yes. Okay. Before we start, we should know, as I told, we have been discussing on palliative care and everything. So more than a session, I would like to take it as a discussion, because we all are physiotherapists. We are working in the same field, so we can take it as a discussion of more than a session. Okay, change the slide, Vaishnav. Next slide. Yes. Before we start, we have to know, we have to brush up basics and everything. So we all know what is health, and can you go to the next? Yes, health is a state of complete physical, mental, and social well-being, and not merely the absence of disease or infirmity. We know this is the definition of health by the WHO. Next slide. So next, we have been studying about palliative care. What is palliative care? The importance of palliative care in physiotherapy. So I want some of at least one of our participants should tell the importance of palliative care, or what is just palliative care. Can anyone help me out in this one? I can see Smita Mary ma'am, Kumar Velsa. Can anyone of you help me out in this? Smita ma'am, Kumar Velsa. Vandana ma'am was there, but she was just went somewhere for some urgency, I think. Okay. Okay. So what is palliative care? Vaishnav? Okay. Palliative care is the prevention and relief of suffering of adults and children. Can you hear me, Vaishnav?
Sir, yeah, we can.
Okay, palliative care is the prevention and relief of suffering of adults and children living with serious, chronic, complex, or life-limiting health problems and their families. Palliative care is the prevention and relief of suffering of both adults as well as children. And we are not treating not only the person with the disease, but also their families. So the key message from palliative care is for serious health related suffering, and suffering can be either physical, mental, social, or spiritual. And the importance of palliative care is we have to reach people where they are and when they need care. So we will be going to the people. Usually, in our normal clinical setup, the patient will be coming to us, and we will be treating them, and we will send them back. But in palliative care, mainly we are going to the person who need us or need care, and we will be going to their place, and we will be treating that patients. Next slide, please. So next thing is disability. Disability is any condition of the body or mind, that is impairment of mind, that makes it more difficult for the person with the condition to do certain activity, that is activity limitation, and interact with the world around them, that is a participation restriction. So we can tell disability on our activity limitation and participation restrictions. If they have any impairment on their body, it will be like activity limitation, and when they have some impairment in their mind, they will be having participation restriction. And the common word, when we can tell a person is a disabled, or he's we call them either disabled person or person with differently able or something. So when we can tell a person is disabled, can anyone would like to answer for that? When we can normal this one, when we can call a person is disabled or something like that? Anyone from our participants?
Hello.
Yes,
Hello.
sir.
Can you able to hear me? So if the impairment is permanent.
Sorry,
So
sir.
if the
Actually, your
impairment is
voice is
permanent.
little bit low, sir. Can you speak little bit
Okay.
louder, sir?
Yeah, when the impairment is permanent. So when the
Ah.
impairment is permanent, for example, if the patient is having reduced range of motion or muscle weakness, it is a type of impairment. When it is permanent, then they may get the disability. That is, they are not able to do the functional activities.
Functional activities. Yes, thank you, sir. Thank you very much.
So
Yes, sir. Go ahead.
that is a disability.
Yes. Okay. Thank you, sir. Tarun sir also mentioned that not able to perform a function. Yes, correct. But for now, I can tell you a scenario. Suppose I'm a person with some disability, and I'm lying on my bed, and beside that bed, like one table is there, and water is kept on that table. I'm not able to get up from that bed and go to that table and have that water. I'm feeling thirsty. Can I be called like disabled? Have you got that scenario? Like suppose I'm a person with sickness or illness, and I'm lying on a bed. In the same room, I'm having a table with a like bottle of water and a cup, but I'm not able to get up and go there and to have that water when I feel thirsty. Can I be called a disabled? That's activity limitation. That Arun sir told exactly, sir. That is where we call the activity limitation. I have certain limitation, or I have to alter my activity to complete that task. That's the activity limitation. And when they have impairment in on their mind, they will be called as that. We'll called as participation restriction. Okay. Now can you move to the next slide, Vaishnav? So suppose actually there are many reasons to be a bedbound or bedridden. So care of bedbound or bedridden is very important in our clinical settings or whatever it is. In our homes, we can see a lot of people who is bedridden and maybe since many years. So bedridden patients are usually kept in bed for long periods, presenting numerous motor problems like reduce muscle mass, like particularly evidencing rapid reduction in muscle mass, then bone mineral density, and there will be a physical impairment. That may not be a permanent physical impairment. Sometimes there will be a temporary physical impairment also. Other problems may arise such as pressure sores, muscle weakness or atrophy because of not using that muscle, then muscular shortness, there will be stiffness on the muscle, respiratory complication, blood circulation difficulties, and bone demineralization, which can quickly develop and result in long recovery process. See, all this risk or all these complications can happen very quickly, but the recovery process is very long on all this situation. And muscle weakness is particularly eminent in skeletal muscle depletion after days of admission. For example, and some research says like after 14 days of bedridden, there can be change of grade in muscle strength. When we check a manual muscle testing or muscle grades, there can be a decrease in the MMT even after 14 days of bedridden. Okay, can you move to the next slide, Vaishnav? So this is what we call sarcopenia. So sarcopenia is a syndrome characterized by progressive and generalized loss of skeletal muscle mass and strength. Here, what happens is because of this immobility or immobilization, or because that person or patient is bedridden, what happens is there will be progressive loss of skeletal muscle mass and strength, or generalized muscle mass loss will be there. That is what we call as sarcopenia. It is correlated with physical disability and quality of life. One of the main complications, particularly frequent among older adults and characterized by muscle mass and function loss. Usually when we tell sarcopenia is very common among like older patients. Actually, we had a patients in recent days. Actually, she's around 65, 70 years old female patient. So 1.5 years back, she fell down on her toilet, and she got a fracture of her tibia of left lower limb, and she got treated it conservatively, and she was bedridden for that 6 months or maybe 8 months. And after that, she never, because of that immobilization, she never tried getting up from her bed or going to toilet or something. She stopped everything. Literally, she stopped doing all her activities of daily living, and she become bedridden. After 1.5 years, we went to see her, and we understood that that patient is still having enough. She become obese by that time, but she doesn't have much muscle power. She's not able to even get up and sit on her bed. But we started doing regular home care for her. In the beginning stage, we started seeing her daily. After 2 or 3 weeks, we made it like alternate days, like 3 days in a week. And by slowly, after around 15 or 20 sessions, she started getting up from her bed and stand using her walker. And now she walks with the use of a walker. But the main thing was she had a fear that she may be fall again. So that's why, because she's not got up from her bed. So what happened to her was that sarcopenia. There was progressive and generalized loss of skeletal muscle mass and strength, and this is one of the main complication of, and it is very frequent in older adults. And due to decreased immobility, they are potentially more exposed to this situation. In fact, immobilization directly and negatively affects the quality of life in these type of patients. But this can happen not only for adults, but also who is bedridden or immobilized for long period. But in older adults and all, it will be more frequent than younger adults. So this sarcopenia is derived from the Greek word sarx, means flesh, and penia means loss. So there will be loss of flesh. That's where the name comes, sarcopenia. Vaishnav, can you move to the next slide? So what are the important things we have to take care, or we have to note down when we see a bedbound or bedridden patient? There are more mainly 4 things we have to take care of. The first thing is skin care. The one of the main complications we can see on immobilized patient is skin care. If what happens, what will happen if the skin care is not proper, or if we are not giving proper care to skin? Would that anyone would like to answer for that? The main complication if you are not treating the skin well. Yes, of course. Fatima said the right answer. There will be pressure sore or bed sore, what we call it, whether it's pressure sore or bed sore, something like that. But if you are not giving proper skincare for these patients, the first thing, the first complication will be the pressure sore, then osteomyelitis will be there. So the next thing we have to take care of is the exercise. We will be coming to the importance of exercise, then chest mobility or chest physio or pulmonary rehab and cardiovascular rehab we can look up. And the last one is positioning. We will be discussing all these 4 points in today's session. Can you move to the next slide, Vaishnav? See, first one is the, so we'll move to the skincare. So first one is the skincare. So we all know skin is the largest organ in the human body, and the function of skin is, one of the main function of skin is to protection. And it should be when we are bedbound or when we are immobilized for longer period, it should be moisturized to prevent dryness and to reduce the friction when we are lying down or when we are immobilized for a long period. Can you move to the next slide, Vaishnav? So we are told already told that there will be complication if we are not giving proper skincare for patients. The main complication we are told was pressure sore or bed sore or pressure ulcer or whatever we can call it. But it is one of the main complication we frequently see in patients who is not doing proper skincare and who is bedridden. Actually, if the primary caregiver or family members is not educated proper skincare or something, we usually see a lot of patients with pressure sore. As we already mentioned, the main this one of pressure sore is like it can happen very quickly and it takes a long recovery period. So there will be many other complications, like they may not be able to do their ADL properly because of this bed sore or pressure sore, or they will be having pain because of this bed sore. So many things can happen like this. So pressure sore is a localized injury to the skin and other underlying tissue, usually over a body prominence as a result of prolonged unrelieved pressure. We know they will be immobilized for a longer period and they will be bedridden. But when there is prolonged unrelieved pressure, there comes the pressure sore. So what is the pathophysiology of pressure sore, or literally what happens when they are immobilized and if they are not doing proper skin care? Can you move to next slide? See, here comes the pathophysiology of pressure sore. What happens is, like on your left side of your screen, you can see a picture simply telling the pathophysiology of pressure sore. They will be lying down on the mattress or a bed or something, or water or something like that, and they will be having their body weight or body weight on this one. So what happens is there will be tissue in between these two structures. Whenever there is a pressure for a long time, there may be a pressure will be whenever there is a pressure for a long time, there will be a collapse of these blood vessels, because bone will be pushing against the blood vessels. Because of that, there will be a collapse of blood vessels. Then reduce, because whenever the blood vessels or the arterial supply gets gets stopped, the main distribution of nutrition, oxygen to a particular muscle, whatever tissue in our body, through the blood circulation. Whenever this blood circulation gets impaired, there will be reduced nutrition, oxygen to that particular tissue, and upon that there will be also tissue perfusion to that tissue. So what happens is, when the oxygen and nutrition supply reduce, automatically tissue ischemia will get start over that area, and because of the reduced oxygen supply, there will be hypoxia. And whenever we know the cells will be can't live without this oxygen and nutrition, and when it gets reduced, automatically over the time the cell will be causing death. There will be cell death, and because of that cell death, what happens is the cells of death, and that it will cause stress. And what happens is skin gets shut off whenever the tissue death happens. That tissue will get shut off from our body. It is a normal process in our body. So this whenever the skin gets reduced oxygen supply, and when it gets when they are not getting enough oxygen, they will be go for cell death, and after that there will be breakdown of skin. So that's the normal pathophysiology of pressure sores. Next slide, please. So that's the pathophysiology of pressure sore, and the main risk factors of this pressure sore are the friction. What happens is when a patient is bedridden for a bed for a long time, there will be friction. They will be moving to give to feeding or doing dressing, some other activities. So there will be getting friction on the body and the whatever cloth or something air, but whatever it is, whatever underneath the on the mattress, or what sometimes we can see patients who is not able to use a bed. They will be lying down simply on their cot. Sometimes they will be lying down on the floor with a mat. Even I have seen patients who is not able to use a mat. They will be lying down on the floor and all. So what will happen is there will be a friction, and there will be also a shear force happening on the body. Then there will be there is another risk factor is like impaired sensory perception. When they are not able to perceive normally, there it is also a risk factor for pressure sore. Then impaired physical mobility, as we have discussed in sarcopenia, there will be whenever there is a reduced mobility or physical mobility, there will be cause of a loss of tissue function and muscle mass. There also we can it is a risk factor for pressure sore. Then altered level of consciousness in spinal cord injury patients and other conditions, that neurological condition, there will be loss of level of consciousness. When the patient is not conscious and oriented, there will be a chance of getting pressure sore. Then bladder and bowel incontinence. Then malnutrition. That is another one important thing we have to note, because whenever the patient is not getting proper nutrition and diet, there will be a chance of getting pressure sore, especially when they are bedridden or usually. And I have seen many patients, as the patient is bedridden or as he is not doing any activities, even the caregivers or the family members won't feed him with enough nourished food, like proper nutrition he won't be getting. They may think that he's not doing any activity, so if we feed him more, or if we give some more foods, he will become obese. Then it will become a problem. So they won't be giving proper nutritious food. Then dehydration also will become a risk factor for this pressure sore. Then excessive body heat and advanced stage. As age advances, the mobility will be reduced. It will simultaneously reduce. So it is also aging is also a main risk factor for this pressure sore. Can I move to the next slide, Vaishnav? So to prevent this pressure sore, we can do many things. Some of the main interventions we can do is the position change. We usually tell a patient or caregiver, or if a patient is admitted in our IP unit or hospital setup, we will be changing their position at least every 1.5 or 2 hours for a bedbound patients, and every 20 minutes for a wheelchair bound patient. When a patient sits in a wheelchair for a long period, we usually tell them to do push-ups by holding. If he is a paraplegic patient, we can ask them to do some push-ups or something if we have enough upper limb strength. Otherwise, we won't make them sit in a IP setup or in a hospital setup and all. We usually don't make them sit for long if he's not able to do push-ups in the wheelchair. Actually, we have that wheelchair mobilization sessions in our IP session, IP department. After 4 o'clock or something, 3:30 or 4, we will be shifting them to wheelchair, and we will be taking them out. So if a person is not able to perform push-ups and all, we'll usually shift them back to their bed, maybe after 20 minutes or maximum 30 minutes. Then, as I told in the risk factors, we have to manage the bladder and bowel incontinence. Then, to prevent the pressure sore, we can use the special surfaces like air mattress or water mattress, and sometimes we use pillows and this one between our knee joint or ankle joint where the bone-to-bone contacts comes. Then we use cushions when they sit on the wheelchair. If the wheelchair is if they have that wheelchair is not that firm, also we usually advise the patients to sit using a cushion. Then we have to give the proper nutrition and hydration and also exercise. Then sometimes we give massage to prevent the pressure sores with the liquid paraffin and white petroleum jelly, and we teach the caregiver about the massage technique, and we have to make sure he's lying down on a wrinkle-free bed, and nail care. If they have if they are not getting proper nail care, there will be a chance of getting small cuts or something on their body with their own nails. So we'll be advising the caregiver, or if the patient is is admitted in IP, we usually give proper nail care for the patient. Can you move to the next slide, Vaishnav? So here are the some common sites of pressure sores that can happen, where the pressure sore can happen when you are on supine lying, like back of the neck, occipital area, then shoulder or scapular area, then elbow, then buttock, then heel and toes. Next slide, please. This is a common sites for pressure sore when they are lying side on the side lying. If they are side lying for more time, like for a long period, there will be a chance of pressure sores on the ear, shoulder, elbow, then hip. When they are on the side lying, the other thing we have noticed was like on the in between the knees, like on the medial epicondyle side or on the angle on the medial malleolus side. Can you move to the next slide? These are the main points where they get pressure sore when they are on prone lying for prolonged time, like elbow, chin, chest, here the area of pubis area, then knee and toes. These are the main common points or pressure sore areas on all these supine, side lying and prone areas. Can you move to the next slide, Vaishnav? So when a bed sore happens or pressure sore happens, how we can manage it, or what are the management of bed sore? First, the main thing is, as I always tell, prevention is always better than cure. The first thing, primary thing is we have to try to prevent it at any cost. But once a pressure sore happens, like it will be the management will be differ from stage to stage. Usually wound is classified in 4 stages: stage 1, 2, 3 and 4, and 5 stages, and the 5th one is unstageable. And in the first stage, actually we teach caregivers to turn an excellent incontinence control. We will be advising the patient caregiver or their family members to do the proper positioning or like position change in every 1.5 hour or 2 hours. Initially we will be treating like that, and we will be moisturizing or doing to avoid the dry skin or something. Then when the pressure sore is on stage 2, there will be cleaning and dressing with normal saline, and stage 3, 4 and unstageable, we will be doing some surgical debridement, and they will be if slough is there, and we will be doing medication, and they also use normal saline for wound cleaning, which is made from the homemade. We'll usually ask the primary caregiver or family members to clean the wound with the normal saline. So that's the management for medical management for the bed sore. Can you move to the next slide, Vaishnav? So next part, we were telling about the skincare and everything, and now we are to move the exercise part. So Exercise also plays a crucial role in preventing bed sores or their complications, and to a disabled person or whatever condition. When a person is bedbound, we can't tell that is only bedbound patients can be stroke patients or spinal cord injury or muscular dystrophy, something like that. Anyone who is age related or something also, some at the after like age of 70, or whenever they are not able to do their proper ideal, they will be usually bedridden in our India. So we have to take care or do the exercise and everything. Somebody has raised their hand, I think. Vaishnav?
No, sir, you can continue.
Okay, so as exercise also plays an important role in this bedbound patient. The use of rehabilitation interventions to improve aspects of physical function, such as motor, balance, walking speed, and activities of daily life. It may differ from person to person, but the basic core value of the principles of the exercise is to improve the ADL or to improve the quality of life. When a person becomes bedridden, automatically muscle mass decreases and fat bodies remain stable, or it can be increased. Can you move to the next slide, Vaishnav? So here, what are the physical rehabilitation program for bedridden patients with prolonged immobility? As we all are physiotherapists, I don't want to go in detail about like the types of exercise or the normal exercise or something like that. But I had to, I wanted you to think about the normal rehabilitation program. So what are the things we usually do for a normal with a person who is immobilized or bedbound? The key factors here plays are the age. The next one is condition, whether it is neurological, orthopedic, or cardiorespiratory, whatever condition it is. Then the comorbidities. Comorbidities also plays a key role in the physical rehabilitation program. Then the tolerance level of the patients. I have seen some patients who is not able to tolerate movement when they are bedridden for 6 months or 1 year and all. They won't be allowing us to do the passive movements. They won't be, it will be painful when we take them to the full range of motion. So the tolerance levels of the patient may differ from person to person, and it also plays a important or key role in our rehabilitation program. Can you move to the next slide, Vaishnav? So next one is the what are the parameters assessed during the implementation of the physical rehabilitation program. Here are the some parameters which we have to concentrate when we do a physical rehabilitation program for a bedridden patient. We have to see the muscle mass or muscle strength, then oxygen saturation, the age, all these are overlap, like age, condition, etc. The muscle, we have to do the MMD first. We have to see whether any complications happen, like some subluxation or joint dislocation or something like that. We have to check the joint mobility. We have to see the muscle strength. So all these things we have to see before we start with the rehabilitation program for this bedridden patients. These are the parameters where we use on the bedbound patients. Can you move to the next slide? So what is the context where the physical therapy program are implemented is also a like important factor in bedbound patient. Here are some like whether we can do it on institution based rehabilitation or community based or in OPD or home. We can see patients at every center, but what do you think? Like I want some of you to answer for this. Like what will be the useful place, or where will be the appropriate place for this bedbound patient? Would I like to reply for that?
Thank you, sir. But can you repeat the question? Not clear.
No, actually, where the physical rehabilitation programs can be implemented for this bedbound patient, Actually, we can be like, we'll be doing some OPD setup, IIP setup, or community institution, or like outpatient or home, where will be most appropriate
home.
place for. Yes.
Old age home, palliative care institutions, hospices.
Yeah, of course, we can do it. That is actually inpatient, in a place where IP facility is there. That is also a proper place for this bedbound patient. But I think moreover that the home will be the most appropriate place for this bedbound patient. Usually they will be, as I have mentioned in the starting of this session, the palliative care is for serious health related suffering patients. So it is always better to do this program at their home. They will be patients will be more comfortable always at their home, surrounded by their family, their children, the parents, or something like that. So always the first priority will be their home. Then only it comes the IP department or institution based. But OPD and all, it will be very difficult to do these type of rehabilitation programs for a bedbound patient. Can you move to the next slide, Vaishnav? So what kind of devices are used for patients with prolonged immobilization? I never wanted to go depth in that, because we all are physiotherapists and we'll know what all things and devices we can use for each and every patient according to the condition, age, the deformity, or whatever it is. We'll be assessing the patient, and we'll be doing the needful. We'll be doing, if we want to strengthening, we'll be going like that. If we want to do some maintenance for that patient, we'll be going like that. So I don't want to go into detail about that. Can you move to the next slide, Vaishnav? So these are the benefits of doing exercise to maintain good muscle strength, then to improve the range of motion, then to improve circulation, and to make the best possible recovery. That is one of the important thing. To make the best possible recovery, we have to do exercise, and exercise can be beneficial for that, and to fasten the recovery. And the last but not the least, the main important thing is there is no alternative for the exercise. For exercise, you have to do the exercise only. You don't have any other alternative for this exercise. Sometimes when I give some stretching or something to some patients who is having severe like reversible contracture or something, they will tell that they are having pain. Whether do you have anything else other than this stretching? Then I always tell the patients, no, there is no alternative for the exercise. Can you move to the next slide, Vaishnav? Then types and frequency of the exercise. I just mentioned the all the exercise we usually give, but I don't want to go in detail on the types of exercise, because we all are the experts in exercise. So we can select the this one exercise appropriately for patients who needs appropriate types of exercise, like passive, active, and active assisted, strengthening, breathing, stretching, everything we can give for bedbound patients. But as I always tell, it may differ from person to person or condition to condition. Not for every patient, we not need to give passive exercise. Like for example, if a person is burdened with a stroke or something, it is not necessary to give passive range of motion for this his both sides. Like he will be having normal movements or normal strength on one side, so we can just initiate that movement. He will be doing activity, or maybe we can give some active assisted. But if he doesn't have power on the affected side, we'll give that passive range of motion on that side. Then the frequency, usually when we tell the patients, we tells the patient to give at least exercise at least 2 times a day and minimum of 5 days. We usually prefer 12 into 3 repetitions in a set, and 15 to 25 seconds of hold pose stretch, and HR max would be the exercise prescription will be like 50 to 70% of that HR max of that patient. So these are the common types of exercise and the frequency of exercise we usually follow or we usually give for our patients. Can you move to the next slide, Vaishnav? So there comes the chest physiotherapy. Next. So we have discussed about the skincare, then the exercise, the importance of exercise benefits and all. Now we are moving to the chest physiotherapy. As we all always know, chest physiotherapy plays an important role in ICU setup or in the acute stage itself. But it also plays an important role in the patients who is bedridden for a long period. It is a broad term used in research that incorporates physiotherapy treatment techniques that address the removal of secretion and improve airway clearance, thereby help to improve respiratory efficiency. What we are trying to do is we are to improve his respiratory efficiency. It promotes the expansion of lung, that prevents the lung collapse or decrease the workload of breathing. Can you move to the next slide, Vaishnav? Then chest physiotherapy we usually give usually comes in two types. That is conventional or traditional chest physio, which we usually teach the primary caregiver or the family members who is standing, or we will be teaching patient also sometimes in like a breathing exercise and all. We will be teaching the patient itself if he is able to do. We will be teaching the breathing exercise, and that is the conventional or traditional chest physiotherapy techniques and modern or instrumental technique. Can you move to the next slide? So conventional or traditional, as I have told, these are some of the different types of conventional traditional chest physiotherapy, like PDPV, postal drainage along with percussion and vibration, then coughing, huffing. Then the main like use of this traditional conventional chest physiotherapy techniques are like can be self-administered or performed with the assistance. It's need not to be a physiotherapist or a respiratory therapist to do this conventional traditional type. It can be given by the parents or caregiver or even a nurse or somebody who can who is available with the patient. They can give this chest physiotherapy if we teach them properly. Then the other types of like percussion, what we usually call like popping or clapping method. Then vibrations, a rapid vibratory impulse. So these are the types, and we usually see in our IP settings as conventional or traditional chest physiotherapy. Can you move to the next slide? Then comes the modern or instrumental chest physiotherapy, like ACBT, active cycle of breathing exercise, then autogenic drainage, then instrumental such as like PUP, CPAP. Then this one is like high frequency chest wall oscillation and intrapulmonary percussive ventilation. It is the use of using the equipments and that high frequency chest wall oscillation and all. They will be using a wrap on the chest, and with the help of that, they will be getting a effect of chest physiotherapy. And in this intrapulmonary percussive ventilation, they will be having a mouthpiece inserting through the mouth, and that percussion or vibration will be getting from the inside the lungs itself. So that's the modern or instrumental type of chest physiotherapy. Can you move to the next slide, Vaishnav? So here comes the last this one, that is the positioning. We have been telling about the skincare, the exercise, the chest physiotherapy, and last one is the positioning. So positioning promote optimal recovery by modulating muscle tone, and it also provides appropriate sensory information, and it can reduce the risk of aspiration, contracture, pressure sore, joint pain. Sometimes, as I mentioned earlier, sometimes if they are immobilized for a long period, they will be having joint pain. When we even if we are doing passive range of motion exercise also, they will be having joint pain when we take it to the end range. So proper positioning or some positioning will reduce the risk of all this joint pain and the swelling of the extremities. Can you move to the next slide, Vaishnav? And the aims of positioning the immobilized person is to normalize the tone, and maintain skeletal alignment or prevent or correct the deformity of the joints, then promote patient comfort, and to facilitate a normal movement pattern, then or control abnormal movement pattern, and to manage the pressure and to decrease the fatigue. So these are the main aims of the positioning. We know sometimes in IP, whether in home also we'll teach the patient caregiver to roll some towels or using some pillows or cushions. We will be teaching their caregiver how to position a patient, how to position a patient in an appropriate position when they are in side lying, supine, and proms. Can you move to the next slide? So who is the one who does this positioning and all? There are many controversies among that thing, but normally usually everyone in the multidisciplinary team can do positioning for these patients, and our main role of physiotherapist is to teach the appropriate positions for each patient according to the conditions to caregiver. We'll teach the positioning. If a patient is admitted in our IP setup or ICU or something, we will be doing positioning. And when they go home, when they get discharged, or if you are seeing that patient at their home, we will be teaching the caregiver to how to position that patient and how to use the proper cushioning for that patient. So that's about the positioning. Can you move to the next slide? Yes, thank you. So that's the end of our presentation, and I think that is the main thing I wanted to give an insight about the importance of like physiotherapy, or what all ways we can give or enhance the bedbound patients by giving positioning, then exercise and chest physio, and this to prevent by giving skin care. Actually, for this skin care and all, one thing I missed out was like we are the one who is treating a patient, and we will be spending a lot of time with patient, whether it is a nurse will be coming and doing some procedures and they will be going in 15 or 20 minutes, or a doctor will be going coming, they will be assessing, they will be given a consultation, and they will be going. But usually as a physiotherapist, we will be spending a lot of time, maybe 45 minutes or 1 hour, and some patients and all like with a quadriplegia or something will take more than one hour. So we'll be spending time with the patient so we can frequently we will be seeing the patient regularly. Maybe in the case of nurses or something, they will be changing their shift or something like that, but we will be frequently more than other like our multidisciplinary team, that patient. So it will be easy for us to understand the changes in the skin or something. Is there any redness or something, erythema or something, we can notice more easily than others. So it is important us to notice and intervene in the skin care also. So that's all about my presentation. Thank you for listening to me and cooperating with me, to all our participants. Now to Vaishnav. If you want to discuss on something which we have been told, we can discuss it now, or we can move to case presentation, I think. Vaishnav.
So I'm requesting all our participants to kindly unmute or ask in chat if you have any queries regarding these sessions. Okay. So can we move to case presentation?
Yes, Vaishnav. Then after the case presentation, we'll have some discussions.
Okay, sir. Okay. Afin sir.
Yes, sir.
Okay.
Am I audible?
Yeah, yes, sir. Yes, sir. Yeah. So can we start?
Okay. Good afternoon. Good afternoon. Myself, Afin GP. I'm working as a clinical instructor come out at Berlin Navajivan College of Physiotherapy, Malaysia, Trivandrum. It's time to start my case presentation. First of all, the patient is a 26-year-old male, diagnosis of spinal cord injury with the C10 traumatic C6 burst fracture with the C2 to C7 port contusion. The presenting complaints are body pain, not able to do ADLs, pressure sore, inability to cough. These are the presenting complaints of the patient. Then history of illness, the skid and fall from the bike on 14th January 2021. Sudden and forceful hit over the lorry. Then weakness of both upper and lower limbs. Then shifted to nearest local hospital. They referred to Medical College Hospital, Trivandrum. Going for CT and MRI brain, that shows flexion tear drop fracture of C6 vertebral body with the displacement of fracture segment into spinal canal, causing severe spinal cord compression. Then comminuted fracture of C6 vertebral body with the displacement of posterior fracture segment into spinal canal, causing spinal canal narrowing, thecal sac effacement, and significant compression on cord. Hemorrhagic disc contusion and cord edema. Disc disruption at the C5, C6, and C6, C7 level with the diffuse disc bulge and inferior migration of at C6, C7 level. Then referred to neurosurgery consultation. The procedure done was C6 corpectomy with the expandable cage fixation with the autograph. J on 12 into 22, 25 under general anesthesia on 25th January 2021. Then examination part, vital signs are normal. Then range of motion not able to assess because of pain. Muscle power, both upper and lower limb, right and left sides 0 out of 5. And then deep tendon reflex, biceps jerk is positive for both right and left side. And triceps, supinator jerk, knee jerk, and ankle jerk are negative. Then sensation absent below D4 level, perianal sensation absent. Plantar more bilateral, and attitude of limb bilateral lower limb is external rotated. Film score was 0. Pressure sore is present at the right heel and the sacral area. Then the patient is on Foley's catheter for continuous bladder drainage, weak abdominal muscles, and that's why inability to cough. Then treatment and significant investigations are bedside management, physiotherapy, psychosocial support for depression. Psychosocial aspects, poor socioeconomic status, wife and 8 months old daughter. He is the breadwinner of the family. Patient says, I am worried about my wife and daughter, whether I can carry my child in my own hands or not, whether I will come back to my normal life or not. Then medication, tablet cefixime, 200 mg BD for 3 days, tablet pantoprazole 40 mg OD for 3 days, tablet paracetamol 500 mg pain, then tablet tetrafol plus OD for 14 days, syrup loose 30 ml if needed, injection LM WH 0.4 ml OD for 14 days, high protein calorie diet. Then for pressure sore, mega heel ointment. Then the physiotherapy interventions. Our main aim is to prevent secondary complications. The passive range of motion exercise for bilateral upper limb and lower limb to prevent any contractures or deformity. Then stretching exercise to prevent contractures, tense to relieve pain. Positioning every 2 hours to prevent bed sore. Then splints given for upper limb and lower limb for proper positioning to prevent any deformities. That is cock splint and AF4 mainly. Then stockings to prevent DVT. Still sitting with the support with the use of hand the help of Philadelphia collar, advised to use airbed to prevent any integumentary complications. Then breathing exercise and respirometry or tribal to prevent any respiratory complication. Then manual assistant cuff to clear secretion, intermittent catheterization and suprapubic tapping to improve bladder function. Patient education about significant adaptation and changes on the part of patient and his family for living with the spinal cord injury and measures to prevent secondary complications. Main concerns: physical pain, pressure sore, difficulty in ADL, inability to cough. Then psychological depression being a burden, whether I can carry my child in my own hand or not, whether I will come back to my normal life or not. Then socioeconomic, a poor economic background. He is the breadwinner of the family. 8-month-old daughter. Spiritual, why is happened to me? Summary: the patient was a 26-year-old male patient with a traumatic quadriplegia with the physical, psychological, social, and spiritual issues. Discussion points: how to improve quality of life of this patient. Thank you.
Thank you, Afin sir, and it's open for discussion.
Vaishnav, can you go to that concerns slide? Like, so here we can see a typical spinal cord injury patients with all of four like physical, psychological, social, and spiritual concerns. So discussion is open for all our participants. Can give some inputs to get rid of these concerns of these patients. And currently, I think that team doing a good work with the physiotherapy interventions. Can you go back to that physiotherapy intervention slide, Krishna? These are the interventions they are doing currently. So if anyone of us can be add something or like make some changes or give some suggestions, would be good. Not only physiotherapy intervention, I'm telling both psychosocial, spiritual issues too. We have to face that issues also. So our suggestions and recommendations for the his as palliative care is a holistic approach. We have to make interventions on all four parts. Tarun sir. You are muted, sir. Okay.
Oh, it's fine. It's fine. No major suggestions.
Vandana ma'am. These are some faces I can see on my.
So I think the interventions which are going on is perfect. We can add like high voltage pulse galvanic stimulation, or the zinc oxide antiphoresis can also be given for the treatment of pressure ulcer. And as far as socioeconomic condition is considered, many schemes which are going on by the government of India. We can tell about those schemes to the patient also. That would be beneficial for the patient as well as to the children.
Okay. Thank you, ma'am. Thank you for your inputs. What is his pain score of him? Have you mentioned the pain score?
No, sir. No, sir. No, sir.
Is he having any severe pain also, like movement or something, or in breast also, if he's having any pain or something?
Below the level of vision, there is no pain. So in the neck region and all, there is pain.
Then where you are giving the tens? Tens you are giving on which area?
Afin, sir?
Yes, 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 sir.
Kumaravel sir mentioned we can give motorized wheelchair once sitting aid. As of course we can give. We have to get some support from. I think he was solely breadwinner of the family, and socioeconomically they are very poor. But still we have some government facilities, so support system where they can get a motorized wheelchair if they are under like if he's a quadriplegic patient. So I think once sitting is improved or gained, we can go for thinking about giving motorized wheelchair. Thank you for that input, Kumara Elsa. And now the patient is having pressure sore, right?
Yes, sir.
I know what stage is the pressure sore, or how
Second.
second stage. So they're doing they're at home now, and they're doing proper follow up and this one.
Yes, sir.
So I think they have taught the patient caregiver or wife of this wound dressing and all, or cleaning the wound and all. They will be doing that at home.
Wife.
And this patient is on a hard Philadelphia collar. So once will you able to make him sit or something like that
So with the help of Philadelphia Gold, with the support.
with the backrest, or the bed itself having
Bed itself.
okay. So as you have mentioned, the concerns of coughing, you can you are doing some breathing exercise and all. So you can continue with that, or like coughing and huffing, you can try to improve the respiratory system. And stocking you are using, and spin scope, focus spin and AFO you are using. So other than this physiotherapy interventions, can you go to that concerns slide, Vaishnav? So here we have to address also, as been mentioned, he is also having a psychological problem like depressions. We have to address that. We like MDT team, multidisciplinary team, have to address this type of problem like depressions. I think we can give counseling session with MSW or psychologist. It would be beneficial for this patient, not only for this patient but also for his family. Because they have to take over from here, so they have to get a proper psychological support for like counseling and all. Do they know the prognosis of the condition, that this is quadriplegia, and the most possible recovery and all, they know, or they know the recovery?
Yes, sir.
Yes, so here we need to give proper psychological support. Even from our side also, we have to motivate the patient as well as the the caregiver to do some this one. And we as they know the prognosis, we can move to the other steps. Once he is stable with his sitting, or once he is able to once he get rid of from this pressure so, and from psychologically when he feel better, we can go for some vocational rehabilitation. Actually, there are many social the government policies and some the support system where they give vocational rehabilitation support for patients in Kerala. So I think they can apply for that, and upon that, now the patient is not having a proper financial background, and what about the relatives or nearby neighbors? So is there supportive or something like that?
So, some
Okay,
supportive.
somewhat the supportive, and his daughter is only 8 months old, so
Yes.
you have a long way to go. So you have to automatically the patient and even the family will be having severe depression now, psychological problem. So they have to be motivated, and they have to given proper counseling. They will we have to encourage them to go and do the proper or on the like reviews and every month or something like that. And for this also, for socioeconomic also, there are some system for disability pension.
But when you say, I don't want to smash you.
Sorry, ma'am, I couldn't get you. Somebody is unmuted, I think.
So you can continue.
Okay, here the socioeconomic background of the patient is also very poor, and we have to support them. And for our, we have to seek support from the local self government or the government support system. They will be getting a pension for both the patient as well as the caregiver. I think both they are eligible for that, both this one pension, so they can apply for that. And when he starts getting a sitting or something like that, we can go for applying for motorized wheelchair as Kumaravel sir suggested. And we can continue with the other exercises Dr. Vandana ma'am suggested, and we have to support him at least for some more times for this one. And spiritual, they have to get a proper counseling. First usually they will get them to the individual counseling, and after that together they will be family, they will be giving counseling. So by that we can improve the quality of life. That's the main motto of our palliative care, or for giving physiotherapy. We have to improve the quality of life. Actually, I have seen many patients with even paraplegic and quadriplegic. I have seen who is running a small petty shop with the help of their spouses or their family. There are some patients in our institutions like that. So I think once they are getting, when they are encouraged on, when they are ready for it, we can do for that, and will be at this one. And Gargi ma'am has something on chat box. Is there any government helpline to assist patients getting the right help? May it be vocational, financial, as correct, ma'am. Actually, we were discussing about that only. There are some support system. I don't know where all, it is there, but in Kerala, it is the Kerala government has started some this one like that. They will be getting disability pension as well as caregiver pension. And once start getting sitting, especially quadriplegic patients, that muscular dystrophy patients, the patients with severe disability, they will be giving motorized wheelchair. And vocationally also, government will give some support for this initial funding, and all government will be supporting.
Okay, so these are all state level helpline or state level help you can say. But is there any national level helpline so that patient can directly get some benefits from government? Do you have any idea about it?
And national level, even I don't know whether it is start as ma'am.
So I would like to answer this. So Ministry of Social Justice and Empowerment, we need to go to the site of Ministry of Social Justice and Empowerment. There are many schemes which are being running by the central government is there. So we just need to ask the disabled person to enroll for the UDID card, that is the unique disability identity card, which every disabled person has to have. And they after enrolling to the card, and once they receive this unique identity, then on the basis of that they can fill up the form about the like whatever concession or whatever needs they want. So in that particular site, they're going to download the form, and they have to fill the form and just have to submit in the local like at the state level also they can submit in the Department of Social Justice, or they can fill that form online also. And after that, the scheme will going to like help these type of patients.
Okay, okay. Thank you so much.
Yeah, thank you, Vandana ma'am. And so it is a good session, and it was very helpful for us also. Thank you for your sessions. And that's about from our intervention. Vaishnav, over to you, Vaishnav.